So now let's go to the actual surgery, so where we can see this a little more clearly. Okay, so first we're going to try in the pin guide, make sure it fits perfectly, make sure there's no rock. Then we're going to attach it to the fixation base, place it in the mouth, and someone has to hold that carrier guide. The pin guide really tight to the teeth. This cannot move around while we're fixating this to the mandible. So the surgeon's going to start drilling his holes. He's going to drill one hole and then place a pin to more firmly secure that. And then he's going to drill another hole, place another pin. So one by one, we're making this guide more and more secure until we have all of the pins in holding this appliance. Now we're going to lay a flap. The teeth are going to be extracted, and then all of this bone is going to have to be removed above this fixation base in order to have enough restorative space. So the osteotomy is done. In this case, a surgeon just used one of those saws and just took the whole bone right off all in one fell swoop, and then just did a little bit of further adjustment. And then the carrier guide is good to try in at this phase, because if there's not enough bone reduction, the carrier guide won't seat. So this is a nice check to make sure that we have enough bone reduction. If it doesn't seat, the surgeon has to go back in there and take a little more bone away. Now we place the osteotomy guide onto that fixation base, and one by one we're going to follow that menu that the laboratory gave us, using smaller drills and then larger drills, enlarging the osteotomies. Going to a larger drill, and then placing the implant through the guide. The little lines on the carrier of the drill show you what depth that you should place these. And so now we have all of our implants in place, with the fixation base also still in place. Now when you're placing your cylinders to do the pickup, sometimes the implants could be a little bit subcrestal, and so you have to get the bone out of the way so it doesn't prevent the cylinders from seating. So this is called a profiling drill. It just takes away, it's a side cutting drill that takes away a little bone so the bone doesn't get in the way of seating the cylinders. And here's our temporary titanium cylinders that are connected directly to the implants. And this is our carrier guide. And this just shows how clearly, when you have appropriate records, how accurate this is in terms of things being in the right place. Because I've had some instances where guides, you go to put the cylinders in and they're not coming through the holes and there's some error, and there can be many reasons for the errors. But in this case, this was really an accurate planning that's going to make our life easy. Now we're going to place the rapid appliance with the holes over the cylinders. We're going to block out the holes where the screws are with these little blue pegs so that the acrylic doesn't go down inside of there. And then we're going to inject the acrylic around those cylinders to connect the prosthetic to the cylinders. And here you see after we've unscrewed it and removed it, and just shows the importance of the rubber dam, because even with the rubber dam, we've had a little bit of acrylic that's squirted through here, and sometimes they could cause trouble in terms of removing that appliance. But in this case, it really wasn't a big issue. And that's the rapid appliance out of the mouth. And you can see why, even with regular screw retain cases, those holes can be quite big. It can weaken these prostheses. And so we don't want the prosthesis to break during the healing time, because it might affect the healing of the implant. So this is the disadvantage of these direct pickups with cylinders like this, is the big holes that you sometimes have to create to pick them up. Here's the intaglio of those temporary cylinders. And now we're going to connect some analogs to the temporary cylinders. And then we're going to bring that prosthetic with the analogs, we're going to fit it to this C2F model. If there is any impinging on the model itself, you have to take a burr and just make a little space so that it's not moving those analogs in any way. And that's just a view of, again, how perfect that planning was and how everything fits, even though we're going from mouth to model. Everything just lines up just the way that we planned it. Okay, so now it's time to transfer the implant position to the C2F model. So what we're going to do is we're going to secure everything so that everything is really tight, nothing's moving around, and we're going to inject some dual cure composite into the C2F model to hold those analogs in place. And once that's set, we now can unscrew this. And now we have a perfect model that exactly replicates the mouth. So everything should fit passively when we go to seat the final prosthetic. So we want to try on the final prosthetic, the one without any holes in it, with just the wells underneath. Make sure it fits, make sure nothing is binding. And then we're going to place our locator abutments, torque them to 25 Newton centimeters to simulate what it will be when it's in the mouth. And then we're going to verify that the prosthetic fits perfectly on that model. We're going to make sure there's no little gaps where these little rests are here and here. And that way, when we place this, we're going to know that the occlusion is going to be nice. We're not going to have a lot of adjustment to do. So on the C2F model, we're going to, again, block this out with rubber dams so we have less cleanup to do. We're going to place our processing housings. We're going to place the final prosthetic on those little pegs. And in this prosthesis, we have little vent holes that we can inject the material through so that it'll go all around those little the housings and pick them up. Once that's set and we light cure it, now we have our housings with our black inserts ready to go. We're going to clean this up. We're going to fill in any little voids. We're going to polish it, and now we'll be able to try that in the patient's mouth. That's before the cleanup. That's after the cleanup. And then we're going to bring those same locator housings that we did the pickup on the C2F model to the mouth. We're going to torque them again to 25 Newton centimeters. We're going to try the prosthesis in with the black insert still in, do any occlusal adjustments we might have, take it back out and polish it, take out the black housings, and then put in our tan housings on the posterior and the anterior, and our blue housings in the middle spaces. And there's our final prosthesis. So no holes, just like the fixed prosthesis we've been working on today. So there's our final result in the mouth. We do the same thing as we did in our little exercise today with the little clicker. And this prosthetic just went right to place exactly how we wanted it. There's our upper conversion in the mouth that we did a conventional pickup with MUA abutments. And these are those MUA abutments that we call SRA on the top. So this is screw retained, does not come out of the patient's mouth. And this is our locator fixed. Now, when we went back in there to put these locator abutments, we noticed there was a little play on this one right here. And so we didn't want to load that one. So we did not we took the locator out, we let this heal, and it healed up, fine in the long run. But we just didn't want to load this implant because it just didn't have enough initial stability. And so here's our patient at the end of the day. With the upper Oh, okay, and I'm not gonna, it would take an hour or two to go through the prosthetics of this, but at this point here, I've completed the upper zirconia screw retained prosthesis. So that's your final prosthesis. And the lower is the first prototype. It's a PMMA milled prototype, locator fixed, connected to all 6 implants now. And that's the final result for the patient. Little close-up. And we will, as our next step, be making her a zirconia locator fixed, because that's what we discussed in the beginning. But for all intents and purposes, this could be your final restoration. This milled locator fixed could be your final restoration. And again, you'd have to think about that and plan it, determine your lab expenses, and dictate your prices based on how far you're gonna go with these. Another thing that you could do for a patient whose maybe finances are limited, you could tell them that, okay, we'll bring you to this stage and it'll be this much, and then when you're ready to have your final monolithic zirconia, which could be 6 months later, a year later, 2 years later, whatever, then this is the additional amount that you would pay to get that final, that final prosthetic. So there's a lot of flexibility with locator fixed.
Doctor, I was going to ask, as the thoughts changed? There was people for a while that advocated, upper zirconia, lower something else. Mm-hmm. Sometimes they wanted to avoid the clicking of the
right.
teeth. Sometimes they wanted to avoid the excess forces on the implants. Is there any thought on that? I mean, I've done it all ways too, but what's your thoughts on it?
Yeah, so anytime I do a double, I'm doing monolithic zirconia against monolithic zirconia. And it was out of, I really didn't know what it was, but I just felt it was such a nicer prosthesis. Like when you take off a monolithic zirconia prosthesis for a hygiene, and you look at the tissue's just golden. It's beautiful. There's nothing sticking to the bottom of the zirconia. It's shiny, it's smooth. When you take off an appliance or a prosthetic that is acrylic or even PMMA, you're always seeing more tissue inflammation, more stain. So I have not found that zirconia to zirconia creates any problem. I've done over 700 cases. I probably have 400 cases of zirconia to zirconia. We have not, from the time I started, knock on wood, lost one prosthesis. We've had a couple patients that didn't clean very well and they lost one implant, but the prosthesis would still work. Time testing for me shows that zirconia against zirconia works. And I've probably had 2 or 3 people come in and say, what about this out? And they're tapping their teeth. And I go, well, don't tap your teeth. And but the other thing that could happen is if you open their vertical too much, just when they're swallowing and their teeth are tapping, it might be because you open the vertical too much. Because when we're speaking, our teeth aren't touching. So even those patients, though, that I just said, well, just don't tap your teeth, they're all doing fine now, too. So I don't see any negatives to zirconia against zirconia. Okay, who's got the time?
2:15.
Okay, so we're supposed to go to 3:30. This is my concluding slide, but I have another case too that we'll go through to end the day. But just some of the things that we've learned. We've introduced locator fix concept. We reviewed the indications for locator fix, presented some step-by-step protocols for patients treated with locator fix, and we've demonstrated the laboratory procedures to deliver a locator fix.